Is that louder? Oh, it's much louder. Okay. So he's from Garden City Clinic in Johannesburg, and his research areas include head and neck trauma and cancer, which is going to talk about today, but also pulmonary hypertension and vasoreactivity testing, ECT, and ketamine in the management of depression. He's published 15 papers in many journals, and including 7 book chapters, and is presented at many conferences, including surgical, anesthetic, and also Islamic Medical Association congresses. So, Dr. Bashir Bulbulia.
Assalamu alaikum, thanks for coming through. I'm an anesthesiologist in private practice. I'm going to talk about cancers in South Africa, but with the emphasis on head and neck cancers, and a brief overview of laryngeal cancers. Okay, this presentation will outline the leading cancers in terms of cases and deaths, the management strategies in 2 case studies of laryngeal squamous cell carcinoma, the treatment modalities. We look at genetic biomarkers, and we look at risk modification issues. And then perhaps on the general note, just end of life issues. This is a generalized bird's eye view of leading cancers in South Africa. It's the global column, which is the Global Cancer Observatory, and you have the age standardized rate of cancer, and looking at incidence and mortality. And you can see that prostate, number 1, breast, number 2, cervix uteri, number 3, lung, number 4, and colorectal. These are the five leading cancers in South Africa. Now, in terms of incidence, we're looking at in males, the common cancers are prostate, lung, colorectal. In females, breast, cervix uteri, and colorectal. Mortality. Lung in males, cervix in females. If you combine the two, you'll see that lung cancers is the highest mortality rate. So, lung cancer is the leading cause of death worldwide, and so it is in South Africa. Now, depending on its location, laryngeal cancers could be one of three: supraglottic, glottic, or subglottic. And worldwide, it makes up 1 to 3% of newly diagnosed cancers. How do they present? They present with voice changes and respiratory difficulties. These are the classic presentations. They may have other things like weight loss, coughing up blood, or expectorant, or a neck mass. Diagnosis is by direct laryngoscopies, which allows for biopsies and information so that we can stage the tumor and subsequent surgical planning. Imaging studies are useful, and these are MRIs and CT scans. Now, laryngeal or oropharyngeal cancers are staged according to the TNM classification, which is adopted worldwide to improve patient management. T, primary location, nodal metastases, and M is distal metastases. Now, 2 case studies. This is a 83-year-old man who presented with voice changes and slight shortness of breath. If you look at what we saw at laryngoscopy, is a cauliflower lesion that had almost occluded at the laryngeal orifice. Now, he had comorbidities that included ischemic heart disease, hypertension, and cognitive dysfunction. He was classified as stage 1 and OMO, and he was a candidate for what we call endoscopic laser removal done transorally. No further treatment was offered as the patient was failed and immobilized. So you see before and after pictures of his cancer. Case study number 2, a male 60 years old, history of dyspnea and severe shortness of breath. Past history of smoking and alcohol use. From the age of 30, he averaged a pack a day and had more alcohol over the weekends. At the laryngoscopy, what we saw was almost a pinhole where he could move in air and where he could breathe. We did a debulking and biopsy, and at the end of that, it gave us some leeway so that we could plan what the next step would be. He was a T4 NOMO and scheduled for total laryngectomy. That's him post-ICU, post-surgery ICU and ventilated, and he's now left with a TOP or patient tracheoesophageal prosthesis to allow him to do esophageal speech. Now, post-laryngectomy challenges relate to this because communication becomes extremely difficult and it impacts on his social life and his work life. In addition, the other difficulties like infection, fistula formation, swallowing, difficult breathing. In general, these are the treatment modalities: surgery, endoscopic resection, or total laryngectomy. Radiation therapy may be, radiation chemotherapy may be as recommended by clinical practice and oncological guidelines. Also, keep in mind targeted therapy and immunotherapy, but these treatments are exorbitantly expensive and it's not easily accessible. What has been a game changer? You saw one was transoral resection and the second patient is a total laryngectomy. The game changer has been advances in laser technology, which allows for transoral resection of these tumors. Secondly, advances in anesthesia, where we're able to do total intravenous anesthesia, we're able to do cerebral function monitoring, and in addition, we're able to use standard cardiorespiratory monitoring. Now, Third game changer was two landmark trials. One was the Veteran Affairs VA study in 1991, and the other was the radiotherapy oncology group. They maintain that equal oncological control is possible with chemoradiation in patients with a functional larynx and intact cartilage. Now, in the second patient that we saw that needed total laryngectomy, the tumor had eroded into the thyroid cartilage. The study by that gave the facility, it was a recent study in 2023, he said that chemoradiation in his patients alone had a survival rate, a 5-year survival rate of 54% and a disease-free survival of just less than 50%. So you see the contrast between total laryngectomy and transforaminal resection. Okay. Global 2022 figures say that the annual number of cases are 955 of laryngeal cancer, and the annual deaths are 570. What are the major risk factors? Alcohol and tobacco use. Both, or together, they are synergistic. Roos et al. In his study, the South African study, found that 98% of his patients had a smoking history and 84% had a history of alcohol use. Okay. What are the benefits of stopping smoking? It improves cancer-related mortality significantly with each decreasing with each decade. WHO, the World Health Organization, says that there is a global decline in tobacco use from 1 in 2 to 1 in 5 from the year 2000 to 2020. In the US, they've seen a decline of laryngeal carcinoma from 4.5 to 2 per 100,000, and a corresponding decline in death rate in the same period. What is the link between alcohol usage and cancer death? 47% of alcohol attributed cancers come from heavy drinking. Moderate drinking, less than 20 grams per day, reduces this risk by 14%. The other risk factors are infection with HPV 16 in the larynx, immunosuppression from whatever cause, HIV or transplants. Just a quick word on the molecular basis of laryngeal carcinoma. The presence of biomarkers. One is calprotectin, which is elevated in patients with laryngeal carcinoma. Now, calprotectin is an inflammatory marker in colorectal disease, and also it is associated with a poor prognosis in patients with laryngeal carcinoma. The second is microNAA, which is useful in head and neck cancer carcinoma because it may act as turning on genes that can act as tumor suppressors or oncogenes. Now, this kind of information is still being unraveled, and hopefully we'll get more information in the coming years. In conclusion, to have cancer is a devastating sentence, and this is the typical grief reaction. The emotional response over time, we have denial, anger, bargaining, depression, and finally acceptance. Now, the important thing is the role of spirituality in coming to terms with this. So, if left to counseling patients, it's important to give them a sound spiritual basis that will act as a bulwark. Just to say, there's a prophetic saying that if you want to improve longevity and your risk, then maintain good kindred relationships. That means good family relationships. My concluding remark is that the WHO estimate that by the year 2030, 70% of cancer deaths worldwide will occur in low-income groups and in countries, low-income and middle-income groups with the resources for prevention, diagnosis and treatment are few or non-existent. Thank you.
Okay, so again, thank you for our speakers for sticking to the time, and yeah, you might as well stay. You're going to be up for the questions. Any questions on the topic?
Bashir, how do you manage the airway in these patients, especially when you're doing the anesthesia?
Yeah.
How you ventilate?
Yeah. Initially, what happened was, when they get seen in extreme respiratory distress, it's the usual, is it a tumor? So we get an ENT to have a look at it. There's a fiber optic examination to give him an assessment. And the patient is kept in ICU, given is nebulized with adrenaline, and if he's still not settling, then it would be an emergency tracheostomy. But in theatre, I have to have an idea of what that airway is. Can I ventilate? Then I use the manual jet, or rather jet ventilation. As long as I can get the chest to expand, we can get by. The surgeon is ready that if he needs to be an emergency track, he's able to do it.
Is there any relationship between laryngeal cancer and people not chewing like they do with oral cancers?
More so with oropharyngeal tumors. And there we're looking at even not chewing associated with esophageal cancers. Not so much with laryngeal series.
Does the use of regular use of alcohol-containing mouth sprays and mouthwashes have the same effect as drinking alcohol and combined effect smoke for putting you at high risk of developing cancer?
The thinking is that alcohol in moderation has some benefit, but we have to go by what we know, our Islamic injunctions. So more often than not, moderate drinking can lead to excessive drinking. And, they say give you 20 grams a day is safe, but one doesn't know.
The mouth sprays and mouthwashes that contain alcohol, a lot of them contain your mouthwash and mouth spray.
Oh no, I don't think that's an issue.
We have a lot of smokers. We have a lot of smokers that maybe they bring to in public place, see their wife and girlfriend, and then they tend to use a mouth spray. So smoke a cigarette, use a mouth spray, and think that they're safe. But those products that contain alcohol that we use as mouth sprays and mouthwashes actually put you at higher risk for developing laryngeal cancer.
My opinion, I don't think so.
Supposedly, you want to get to the effect of alcohol swallowing.
My question is that the patients who underwent laryngectomy for laryngeal cancer, of course, they after laryngectomy, so he will be tracheostomy, yeah? Yeah, so it will keep tracheostomy for him at the end of his life, yeah? Because there is no way to breathe from larynx. So he had to breathe from his tracheostomy, from tracheostomy. And can he speak after that? Can he undergo special learning for how to speak or how?
It's a huge challenge because they have to learn esophageal speech, which means they take in a breath and then they prove the prosthesis and then they speak. So it impacts hugely on their social life and their work life.
Thanks for that. Is there an association between laryngeal cancer and vaping and other electronic cigarette devices that more of the young people are using?
I think it's vaping and cancer.
Yeah, I think that vaping is not safe. Overall, it will not have the carcinogenic effects of alcohol. But we've seen patients with HPs of 20, and that comes from vaping. And I think somebody published recently on vaping. It's really not a safe procedure at all. A safe indulgence rather.
Okay, so any more questions? The last chance? Right.